waveforms that were sent to us from different people that actually have good teaching points for all of us. Today is October 19, 2021, and so welcome to SEVA VentRounds. I know that we'll have a good time learning today together. So let's go to our first. Okay, so first, just as usual, we discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion, and it does not represent the Cleveland Clinic's. These are my disclosures and rubs related to conflicts of interest. We mute the sessions, just so keep your microphone muted, but if you want to convey anything, just unmute and chat with us regarding whatever you want. We also use the chat function. I invite you to put your questions there or unmute yourself and just ask us as things come up. And we also use the WebEx function, the poll, but I don't think that today we're going to need that. This is going to be, there's very, very nice cases to discuss today. So the first one was sent by a person in Twitter, Dr. Satish Chandra, sent me this waveform, and this is from a different ventilator of what we usually see here at the clinic. And so I thought that it would be interesting for us to get engaged and go on the and go over it. So I'll ask what I don't know if there's any of our first year fellows on the line that wants to give it a go. I don't know, Erin, are you up for it? Any fellow that wants to comment?
I could go.
Oh, thank you, Stephen. Go ahead.
Okay. All right. So it looks like it is probably PC, CSV, S. And I say that because it's not so. Well, for one thing, it's spontaneous. For two things, the pressure seems to be level at the top, and there's no uniform flow waveform. Okay, what's the load elastic resistive PMUS? Well, when it's CSV, it's almost always PMUS. So I'm going to go with that one. And just because the patient's breathing so much, you won't really be able to assess the elastic and resistive load very effectively. Okay, PV discordance. Well, let's see. And let me just make sure that it's in fact spontaneous. Just before I anchor on this, it says CPAP PSV, so that's probably making me assume that. And all the settings appear to be for that rather than inspiratory time. There's no set inspiratory time, so I'm assuming that's just the patient cycling. It looks like the cycle threshold is probably 1% of the peak flow. So this is all fitting for a standard CPAP. So anyway, any PV discordance trigger, I guess the trigger is as set by the patient, so that's normal. Inspiration appears to be normal. There's no evidence of work shifting. Cycle appears to be normal. Again, I think it's just probably like 30% of peak flow or something like that. I'm trying to read the ventilator and see if it's set on there somewhere. And then expiration. Okay, so I mean there is some expiratory work. The line is a triangle rather than a concavity, but that's expected. So I'm trying to see what the what the interesting thing about this is. I'm sure there must be some trick in here somewhere. There's something funny here about the way the expiration goes. It's a very short inspiratory time and a very long expiratory time with a slow expiration. I don't know if that is of any significance, if it's a patient who has some obstructive disease and is subsequently compensating with a low rate. I'm trying to look and see if there's anything else funny going on here that I should pick up, but I can't think of it.
Okay.
Probably a trick in here somewhere.
Very good, Steve. And that's why I placed this one when Satish sent it to me. I thought that it was a good testing grounds for us. He was playing with the ventilator, actually walked in, and then he modified a setting. So let's start by the beginning. I think that you read this very nicely. Pressure control. It is CSV, as obviously it's very hard to from here you could say, well, they all look the same, Eduardo. And so I think that if there was not this big white sign in the center, you would probably you would have some trouble deciding if it's pressure control versus pressure support, or spontaneous versus mandatory. And its set point, as you isolated rapidly down here, you set the inspiratory pressure. I would say when I see this, I wonder for this ventilator, this is probably the case, that it changes color when it's triggered by the patient, and some ventilators actually maintain that until the patient cycles. So just pointing out what's cycled by the patient, triggered and cycled by the patient. And that may be also a clue of what you're seeing there. So absolutely, pressure control CSVS, the name on this mode, this is a Engstrom ventilator, so it's CPAP PSV. The load during inspiration, I fully agree with you. It's bulged up, or concave or convex, so it just goes with PMOS. And then the expiration, maybe there's a little bit of concavity. I'm not entirely sure. I presume that this is a second, so 1, 2, 3, 4 seconds, and this is the baseline. This is 0 baseline. We'll come to that. So, but it could be either normal or increased resistance just by the way it looks. The peak flow is decreased, and it takes a long period of time to get back to baseline if we consider this 1 second of time, and this is 1, 2, 3, 4, 5, and we're gonna talk about this little hump over here. So either normal or resistive would be my two options. Steve, does that make sense?
Yes, that makes sense.
So let's talk about the trigger, and when we start with the trigger, you're coming, and this is the 0 is the 0 flow, and essentially in general what you will see is that in the literature we describe the start of inspiration when it crosses 0, and so you can see that the flow actually crossed 0 down here, and it kept going up until it triggered. And actually related to that, you can see that the pressure had come down, not as fast as you would want, but down towards what it would be PEEP, the PEEP level of 5. And then suddenly there's a drop on this, and then boom. So all of this area under here, the patient had crossed 0, the pressure had gone below baseline. So now that I have shown you that, what do you think is happening?
It is interesting. I guess my first thought on it would be that, well, one would be that the patient makes some extra expiratory effort at the end, but if that happened, then you would think that the pressure would go up rather than pressure go down. So that doesn't make sense. So it's almost like something is released at the end. I think some CPAP machines have an expiratory release programmed in. I don't know if that has to do with this, because this is probably not a CPAP machine, it's probably a ventilator. But anyway, other than that,
So if the patient does inspiratory effort, what will happen to the flow? It would move up or down?
Oh yeah, you're right. I guess that would be inspiratory effort. The flow would go up.
And then the pressure would go down.
Pressure would go down, yeah.
So if the inspiratory effort started over here, right here.
I see. So that would be basically that the patient is trying to start the inspiration, but doesn't. So I guess I'm not sure if you call that perhaps a failed trigger, or I don't know if we
Would you call that a late trigger?
Yeah. So the patient started, and the ventilator took a long period of time, and then poof, it gave you the breath. When it's a failed trigger, what you would expect is that there is no actual P vent, that this would continue, that you would have the drop in pressure, and no P vent there, and the flow would have gone up and down like that. And you don't see that. So you see this, and then at the end of it, it finally triggered and it got through.
Okay, yeah, that makes sense. So it's still within the same trigger, it just takes a long time to get to it.
Yes, 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 exactly. So this is a late trigger, Steve. And if you had to guess, which one do you think is a trigger? Do you think it's a pressure trigger or a flow trigger?
Well, normally you could look at the coloring and the one that's on would indicate, but in the absence of that, I guess the fact that the flow already becomes positive without triggering it means that it's probably more likely pressure triggered.
So the opposite, and the reason is, you see how it plateaus here. It actually starts going. There is no more change on the pressure, but this was continued to go up. So, and I know this just because Satish sent it on the email to us, but he changed the threshold triggers for flow, so he went higher. So now the patient had to do more effort, and then you get this late trigger. So the solution for this was to decrease the threshold to something lower so that the patient could achieve happiness, and so that he would be triggering all the way over here. Make sense?
Yes.
Perfect. So and that's the importance of that, now and then changing ventilator screens and showing you this so that you can because we get very used to what we see otherwise elsewhere. It happens to me all the time. And then inspiration, I agree with you. It's essentially normal, very minimal work shifting. The cycle, I think, is normal. There is no evidence of after or before effort. And then expiration, the expiratory work, perhaps a little bit, as you said, or some amount of resistance. So now that we have done that, what would you change on this patient?
It would be, we said it's pressure triggers, it would be to lower reduce the pressure trigger threshold.
Reduce the trigger, whatever trigger threshold it was, either flow or pressure trigger threshold. That would be your first action, and to help this late trigger to go away.
Oh yeah.
Because
Sorry, it was flow triggered, but yeah.
All of this area is wasted effort from the patient. This is a lot of effort that the individual is doing, and without getting any of what he wants to get. And so that may have bad outcomes in the long term. All right. Very good. Thank you. Thank you, Stephen. Very, very nice discussion. Any comments from the team? All righty. So let's do another one. Do I have a volunteer?
The next one, Dr. Mireles.
All right. Well, Samid, this is a courtesy of Ariel Garnero. He's a respiratory therapy in Missouri. He sent me this teaching, one of his slides. I think it's beautiful. So I put it completely as he sent it to me. No manipulation of any sort.
All right. So the tag, I think, is pressure control, and it's CSV, I think, with servo, and R. Yeah. So I think there's the EDI peak and min. There's basically NAVA, and it's trying to size trigger and cycle based on patient's input. The load, just looking at the inspiratory flow waveform, it's one time constant, and then the expression is around 1 to 2. There's a little bit of concavity. I would say inspiration is PMOS because it's just convex the flow waveform. Um, uh, expiration is, but that's on the first wave. The second, there's this trigger, and then there's a breath, and then and I think expiration, I would say there's it's finishing within 1.5 time constant. Maybe it's more elastic, just because it's just taking 1.5 time constant, which is fairly short. But then he resists to 0, so I don't see any other resistive component there. PV discordance. Now the trigger for the first breath, I think it's pretty congruent. There's a NAVA spike that results in a breath, but for the second breath, there's a mandatory breath that is given, or at least a non-triggered breath, a machine-triggered breath that's given, followed by sort of a patient-triggered breath, which corresponds to the spike on the NAVA. So it it could be for the second breath, I would say early triggering, just because there's no effort and then it's a trigger that happened. For the first one, I think it's pretty congruent. I wouldn't say that the first one is early, but the second one definitely has an early trigger. An inspiration, looking at pressure waveform, I don't see. I mean, there's no like inspiratory work shifting. There's some wave, and I don't know if it's maybe it's just my small screen. There is some yellow waveform that is crossing below. I don't know what's this. I think there's this naval waveform, and on that there's this yellow. There is some shifting in inspiration on the second breath, but I could be missing it because it's overlapping the NAVA pressures. And then cycling, the first breath, I think there's no cycling abnormality. And the second breath, I mean, it triggered early, but I'm not sure that would just automatically give it an early cycle, because I can see that in inspiration there's flattening of the flow, so that sort of seems like as if you had introduced it. But the first one is normal. The second one, I would say at least the patient triggered breath is followed by this small pause that would indicate that there is the early cycle, but that could be just because of the early trigger. And then expiration, again, I see a very short time constant, barely 1.5. I don't see any work shifting in expiration.
Okay. Thank you, Samid. Rob?
This is very interesting, and
I love it.
a couple of things I want to point out. The NAVA software has changed. When NAVA first came out on the servo, if you lost the NAVA signal, then it would switch to pressure support. And if you failed to trigger in pressure support, it would back up into all mandatory breaths. So be, pressure control mandatory breaths. Recently, they have upgraded it so that it no longer defaults into pressure support. And the reason I was told was because too often patients would get locked into pressure support and couldn't get back into NAVA, and people thought they were NAVA and they weren't. So I don't have no idea what level of software this is, but I think it's a pretty good read. Everything that was said looks pretty good. The only thing that's interesting here is that we don't know what the apnea interval was set at, so that's probably why that second breath was a mandatory breath, because it was machine triggered. And it looks like in this context, it was an early trigger because, or a reverse trigger, if you will, because after a few milliseconds, the patient makes an inspiratory effort, which you can see from the EDI and from the flow waveform. And that went past the reset inspiratory time apparently and caused what looks like a double trigger from the flow waveform.
So,
I'm not clear on why it was machine cycled. The second one was machine cycled.
so I think that this will help, and that's why I like this waveform a lot. Is I think that what is distracting you is the fact that you have the EDI signal in the bottom. You see the EDI signal and you immediately think that you're on NAVA.
Yeah, that might not be enough. Yeah.
This remember that when you're on NAVA on the old on this ventilator, the Servo I, you can be on another mode and still have the NAVA channel and have the waveform of the EDI on the mode that you set. So in this case, it's pressure control. So, and there's several hints here that this is not NAVA. It's actually PCCMB S. And so let's talk about those hints in general. So let's start with the first breath. Let's walk together through it. The NAVA software, if this was NAVA, it goes by, it triggers by either the EDI, the electrical activity of the diaphragm, or the flow trigger or pressure trigger, whichever you activated, in a first come basis. In this case, what you see, and actually you Stephen alluded to this, you see the changing color of the flow signal. And on top, and actually I'm gonna amplify this for a second. You can see it better there, Samir?
Yeah.
Yeah, so over here you can see actually the overlay of the of what would be the estimated pressure the machine would deliver for the set NAVA level that we would have for this patient. What it serves, because it's essentially the identical of this waveform. And if you think about the waveform from the EDI, this would be the start of the breath at whatever the threshold they put. And then the NAVA always cycles at 70% of the peak. So as you reach peak, it goes down. When you reach 70% of the peak, that's where it cycles up. So this is the start and this is the end. So if we think about the start, you could argue, well, they look pretty close, Eduardo, but at least you have the marker here that tells you that it's likely a flow trigger. But then look at the cycle. And so here's the peak. And the 70% probably would be around here. And the pressure doesn't end. Actually, it continues for an amount of time. And then if you notice on your flows, you see the pause at the end of the flow. That flow tells you that this was time cycled, which goes with a mandatory breath. Again, highlighting that this is PCCMBS. So the interesting part here is that this is a beautiful example of showing not only that the waveform itself can tell you that somebody has a late cycle, because that's where your eyes, if you're in pressure control, you look at the flow waveform. And so in the flow waveform, this is how late cycle would look, with a pause at the end before expiration starts. So I'll just put that there. And then as you come to the next one, you again have a mandatory breath. There's no triggering of this breath, either by the EDI or the pressure. There's no even drop. You can see how it dropped here. There's no drop here. There's no evidence of the flow increasing here. So this is a mandatory breath. Again, talking that this is pressure control, CMBS. And the third breath, it's triggered by the patient. Again, it's late cycle. You see the pause over here. So the three breaths that you have on your screen are mandatory breaths. Does that help?
Yeah,
Yes.
that's great. And if it's in NAVA, it would say NAVA, not pressure control, right?
That's the cherry on the cake.
You get so caught up
All
in
right.
the waveform.
So we talked about this first, the trigger. I think the trigger, you can see actually how synchronous it is. It's pretty good for being a flow trigger. If you had him on NAVA, you would not gain anything here. You probably would gain it on the cycling here. The second one, you identified this beautifully, Samir, in which it's mandatory breath followed by evidence of spontaneous, so from a patient activity. And then the patient activity, the PMOS starts here. And then actually you can, I don't even need to draw it. This is the beauty about it. You can see it starts right around here, which is this point. And then it peaks and it ends around this point. Look at that, right? So you see it with the EDI now here. So that's why the patient triggered the next breath, because there was evidence of effort at the end of the breath. So this is the second breath is an early trigger. The first one is a normal trigger, as you mentioned. In terms of work shifting, on the first one, whenever you see that there's this bulge, there's some amount of work shifting, but it's not severe. It's not dropping below the baseline. So I think that you maybe say that this is clinically appropriate. And then this one is always going to have some degree of work shifting just because the patient is triggering in the meantime, but it doesn't drop necessarily the pressure below the level. And then the cycle, as we commented, this is a late cycle. This is an early cycle, but when it's related to an early trigger, it doesn't really matter. And this one will not matter.
Late cycle.
Exactly, doctor. And then expiratory work is beautiful. Now, there's something here that I really enjoyed, which is this comes very often in our interactions, is what the heck are these spikes?
Yeah.
Exactly, right? It's like, why do I have these little suckers here, right? And they actually are related to changes in the pressure, and you can see them right here. Now, the beauty about this is this the muscle?
I mean, could it be just the expiratory valve just giving us these spikes, or because the NAVA doesn't show any?
So it's not the diaphragm. You agree with me?
Yeah, it's not.
And then they occur at the same interval on both situations. So what does that make you suspect?
That they're cyclic for some reason. They're happening, like they're oscillating back and forth between something. I don't know.
What gives you that on the airway?
Vocal cords.
Well, he's intubated, hopefully.
I mean, trachea and everything is cartilages, and
So usually these, if I see this at the same intervals, that makes me suspect that there is either a mucus dangling there or secretions dangling there, and they're just creating these oscillations. And so I would suction the patient or check the circuit. That's what I would come for. Yep. Any comments? So this is a beautiful teaching waveform of desynchrony with the use of this very nice, the EDI to help you understand what's the synchrony issues with your patient. I hope that helped you eyeball that.
Here's a comment.
So, yeah, go ahead.
They have a NAVA catheter that's working. Why don't they use NAVA instead of pressure control, which is obviously asynchronous?
Fair enough, and that's a clinical question at that moment of saying, well, what's your goal and why did you change it? Right? It could be that the patient was too sedated, the rate is too low, and he's not compensating. I mean, this was not a clinical case for me, but with the presence of the NAVA catheter, then the question is why didn't you use it, or why wouldn't you use it to set up your mode? There you go. Good question. All righty. Very good. I have Okay, we have enough time. So let's do, who wants to do this one? Have no fear. As you see, we're learning. I mean, these are very nice waveforms. They have a lot of information. It can be an RT if they want to jump on. I have no problem with that. Favoring fellows here, being nice. Little tear. Don't be afraid. It looks horrible, but it's actually pretty good. It's pretty decent. Anybody? Right? Okay, given the desire, I'll do it myself. So
All right, Dr. Mireles, this is Aaron. I can try. I may need some help though.
there you go, Aaron. Try it.
Yeah, I've got a mic now. So let's see
Okay.
let's see how this goes. All right, so I have the hint. This is pressure control based on the top, but also looking at the waveform. So we're PC CMVS for our mode.
Uh-huh.
All right, so looking at it, we can see based on the color change and how it's going that the patient is triggering a lot of the breath, but it looks like the flow waveform doesn't look that bad besides the dip down in the beginning. So when I'm looking to see where the work is, I mean, there's definitely patient work going on. So I feel like there is some PMUS, but it doesn't look like there's a ton, like on inspiration, but it doesn't look like there's a ton. I'll go ahead and say that, but may need to come back to that.
Okay, good.
So looking in expiration, it looks like there is a good amount of work in expiration coming up
Okay.
fairly quickly. There may be some elastic, like, yeah, I think PMUS there. For the trigger looking, I mean, it seems like we're not, I'm looking at kind of that early, the drop in flow and then coming back up quick. I mean, obviously the patient, I mean, is double triggering, but it seems like it's an early trigger. And those all look like they're patient-driven breaths. And then when I'm looking at expiration, I mean, it doesn't seem like it's cycling off early. So it seems like the cycle is okay and it's more an issue with the trigger. But I'm not entirely sure it's a very funny looking waveform. I'm wondering what's going on when I'm seeing the drop in the flow initially, like when I'm looking at that first waveform. And then looking, I mean, they all look kind of different, but looking at that third and fourth breath, it does look like inspiration starts before flow reaches 0. So it seems like there's auto peep there and it's starting a little early, but they all look a little different.
This is a tricky one, Erin. So let's walk together through it. I'm gonna be asking you some questions, okay? I was walking in the unit, and this is 4 o'clock in the morning, and I saw this waveform. So me being me, couldn't stop, took the picture, then fix it. So let's talk a little bit. So you're absolutely right. This is pressure control, CMBS. All the breaths are mandatory, even though they're being patient triggered, as you have the color marker, right? All of them are the same size. Every single breath is the same size. And so I think that I have no, the tag is right on. So let's talk a little bit about the load. And when you look at the load, it's really challenging sometimes to see these things. So during inspiration, you have this is a patient trigger breath, and you have the big spike, then it goes down, then it goes up, and then it takes a while to go down. Then there's another breath trigger because it cycles, the flow drops rapidly, and then it goes really high up, with dropping the pressure below the baseline, high up, and then there's these kind of oscillations here, up and down, and then the breath ends, and then there's nothing, and then there's this wacha, 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 and then a little bit of what it seems to be effort, and then another breath get triggered with a bigger drop in the pressure, and then this kind of long drop down. And so trying to read this is crazy because you don't have a nice time to decay. But if the ventilator is doing something, and it's doing something in response to badness. So I agree with you that during expiration, there is PMOS here, there seems to be PMOS here, and there seems to be PMOS here. So I will give you that. During inspiration, because of the way that this looks, that it's taking a long time to go down, within these oscillations that are usually artifact, you see how this is taking a fair amount to get there. And when I see that, it makes me think of resistance. And there's a couple of other clues up here that you'll see in a second. So let's take a look at the trigger. Who's triggering the breath here in this one?
Sorry, Richard, in the second one there.
This one,
So-
yes. Forget about this one over here. We're gonna ignore it for now because we have
Okay,
enough
so like you said, it's a mandatory breath, but the
yes, who
patient, it
triggers?
looks like, is triggering.
In pressure, right?
Yes.
So it's in a pressure setting and it triggered. And you can actually see the flow, how the patient is doing effort, and then he transitions to take a breath in. The breath triggers, and the pressure goes up, then it goes down, the flow goes down, then up. So the ventilator is trying to maintain the pressure at the set inspiratory pressure that you have placed for him. So it goes up and down, trying to calibrate, to adjust. And then it cycles off. Who triggers this breath over here, the patient or the machine?
It looks like the patient.
Because there's color change, right?
Right.
Excellent. Do you see evidence of PMOS here? Much evidence of PMOS?
No, not really.
I mean, if anything, the patient is probably trying to exhale. I mean, it's very tiny little hump here. Then the patient exhales again. And look at the flow. It goes really down up. You see this little thing. And then there's barely any air out. And then there's this. And then the patient tries to do exhalation. Is this a patient trigger breath here?
It is.
It is. You see actually the pressure drop a little bit. The flow moves up and crosses very nicely. Again, the pressure goes in. There is this oscillation to try to maintain the pressure. Then the pressure goes down. And the patient gets, the flow goes really down and then again up, triggering another breath and getting this kind of continuous delivery of breath until it ends, and then the patient exhales. So when I see this, it makes me suspicious that either the patient is triggering two breaths, so he's doing a very big effort like this, right? That is doing a very big effort, or that the machine is creating a false trigger, that the patient is only able to trigger a little bit, and these are false triggers. And sometimes you see that in this ventilator, they have an algorithm that they call, I always forget the name, it's the time constant algorithm or something along that whenever there is very high resistance, the ventilator will try to drop the pressure as fast as it can, and that generates these kind of oscillations on flow and pressure that may trigger another breath. And so kind of the ventilator fools itself into being a false versus a patient that is having a false trigger, and the second one is just the patient is just trying to take a. So those are the two options. That's happening, or that this is an early cycle. Either or is the situation. So I'll ask Rob, what does he think, and where are we going here?
I think I have to agree that this is a false trigger. I think you got the same noise spike on the expiratory side as you have on the inspiratory side.
Exactly. So the same height, right?
Yeah.
So this patient had actually a ET tube obstruction. I mean, he had a lot of secretions and obstruction on top of COPD, and so got suctioned, and that went away. He actually improved. That disappeared. So this is one in which you may want to drop the rate or do an end expiratory pause to see the amount of effort and how long the effort is, or just simply check your, sometimes what I do is I prolong the inspiratory time so that the end expiratory flow is not as high when they exhale, and that the way they don't trigger another breath. So the less difference there is from here to here, the less chance it has to do those big oscillations. Does that make sense, Erin?
It does. If you did an end expiratory where you kind of cleared the secretions in the tube, would you still see those crazy oscillations all the way through the hold?
Well, if you take, no, because you close the flow.
Okay.
So you essentially block him. So that was my suspicion when I saw this. I was walking and said, "Oh, this patient's doing a lot of effort," but essentially he was doing a little effort, and then he was just, the machine was sabotaging him, and he was air trapping on top of that with secretions and not doing very well. You can see the tidal volume was miserous from time to time.
Did you get a chance to take a photograph after you fixed them?
I probably did, but I didn't put it in here. Take a
Oh,
look.
please.
Thank you. That's actually a good point. All right. Very good. Now,
So, Dr. Mireles, this
yes,
is
Russell.
So you're saying the false trigger is triggered because of a high pressure. You mentioned maybe there's this time constant formula. So wouldn't you just bring down the amount of pressure, the amount of pressure above the PEEP to prevent that from happening?
So this is a function. Thank you, Russell, for bringing that up. So the machine has a algorithm that what it does is that in settings in which essentially what the algorithm, this time constant or time variable, whatever it is, I'll send you the link. What it does is it tries to get the pressure back to PEEP as soon as possible. And so actually you can see it on the one before. In this breath, the pressure, the flow went down, and then it decompressed. And you see this oscillation. They try to bring the pressure down as fast as it can to reach PEEP, and that creates these oscillations in flow to try to get there. And so that oscillation may generate the false trigger on the patient. And so it happens in patients with high resistance in the setting of being on this type of ventilator. It's an unintended consequence of the algorithm in patients with very high resistance. And so if you set the I time long enough that the flow reaches zero, then when you depressurize, you don't have those big oscillations, and the chances of you having that false trigger is less. However, in somebody with very high resistance, you can imagine that you would have to set a very long I time, and then the patient would be in trouble. So that may not be the answer for everybody. Does that answer your question? Miguel asked me.
Yes, it does. Just because, I mean, because it's a COPD patient, as you're mentioning, so like setting a long I time is kind of the opposite of what we want to do in these patients. But okay.
Very good. And sometimes what we do is, what they try to do here is what you see is they set a pressure trigger, and you just set it higher enough so that the patient cannot do that. But this may be a perfect patient for NAVA. Very high resistance, issues with cycling and triggering. I mean, and this is the right ventilator to put them on NAVA. So that's what I would recommend.
Okay, thanks.
No problem, Russell. The question from Miguel was, does the algorithm can be deactivated or activated? I don't know. That's a good question. I don't think it can be deactivated. But I don't know, Miguel. I'll figure out. All righty. We have 12 minutes left, so I think that this just not to leave it. Anybody wants to jump on this one? Russell, you want to try it? Is that a
Are you
yes?
there?
Yes.
I should know better what the full NAVA tag is by now. But so just actually looking at the pressure here. So at the very top we have a pressure. I'm outside, so I can't see very well. Let me get to a better area here.
Okay.
So we have 4 things here. We got a pressure on top. It looks like we have flow in green. The volume looks like it's blue, and then I guess the the esophageal probe is right there, and the green at the very bottom are light blue.
Yes.
It looks like on the very top, it looks like it's pressure controlled there. It doesn't look like he's initiating a breath at all there. I know it's an IMB though, based off knowing the NAVA, but I don't actually see him triggering the breath. Or I guess I'd say he or she triggering the breath there. I do see like a downslope in that very first breath, and then it gives the amount of pressure. So like me just knowing that continuous spontaneous ventilation, and then whatever the NAVA is, which is that's not the intelligence, it's the, oh, I guess you wrote it there, the R. So looking at what is the load, inspiration. I don't see any PMUS. I don't see, I guess elastic, I'm not sure. And then on the expiration, looks like you can see it very clearly. The end time is very quick, and so if it's short, then it's elastic. Any PV discordance for the trigger. Like I said, I don't see him triggering it, but it looks normal to me. And then as well as inspiration, normal to me. The cycle looks normal, and then the expiration also looks normal to me. We'll see how wrong I am.
Russell, proud of you. Good effort. So let's do this together. This is actually a pretty cool waveform because it talks about something that we never talk about. Well, but we sometimes talk about, which is neuro-mechanical coupling. And so let's just walk together with this. So we agree this is pressure controls. This is CSV, so continuous spontaneous ventilation, which is servo. And without a doubt, if the patient stops breathing, he would get now pressure controlled breaths to rescue or to maintain them. So in a sense, that's an IMB, Rob. But I guess
It
that
is.
the primary.
Our Rosetta card calls it IMV.
Yeah. Perfect. And it
No
would be
alarm.
RS, right?
The mandatory breaths are just S, but the spontaneous breaths are R or S, depending.
Okay.
Actually, now it's only R. Since they've changed the software, it's only R. There's no S's.
Okay.
For spontaneous.
All righty. So they set it based on the EDI signal.
Yep.
Okay. All righty. The load, I think it's elastic. I agree with you. I mean, you go from the peak to the bottom in less than a second. I mean, that lung is being filled really fast. And actually, you can see that you start a peak of 15, and it goes all the way to 41. So this patient is getting 25 of driving pressure, and just generating 355, but it really empties relatively fast. So I'm with you on that. So then let's do any PV discordance on the trigger. So I know that you guys have a limited view right now, but I'm going to show you this. Now you see the EDI, and you see the color change down here. In the EDI, it's white.
It's like maybe a little white there. Okay.
Yeah.
Purple. Yeah.
Excellent. So now you saw it. So the trigger is actually our EDI. And you set that according to you can modify it. And that led to a little bit of drop in the pressure and the start of the flow. And then inspiration, we talked about it. It's essentially normal. I don't see any work shifting here. But you may say, Eduardo, this sucks. I mean, the waveform actually should, well, that sucks, but whatever you want. This waveform should actually look a little bit like that. Tweet, and then it should drop. Because it's matching the EDI signal. That's how it should look. However, it did not. It's actually truncated. And the reason why it's truncated, actually you can see regulation pressure is limited, is because the software, when you set your NAVA level, the NAVA level is essentially you're gonna get 2 centimeters of water for each millivolt. And you can see here that the peak millivolts are 38. You multiply this by 2, you're gonna get up to 60 of pressure. So the peak pressure on this patient was set up, and the way that the NAVA works is that it will not let you go, I think it's 5 centimeters below the peak set pressure limit.
I think that's it.
So, sorry, thank you. And so then it truncates the pressure, and that it continues to give you the pressure, but it doesn't follow the same amount of pressure delivery that it should. It just simply truncates at that level. So it converts from a servo to just simply a set point. So it starts servo, and so it's a kind of dual, Roberto, no anger, within pure pressure. So it just limits the pressure, and that's why you don't see the nice sharp fin that you should see down here, like that. And so there's no work shifting, but then the cycle. So let's talk about the cycle. Russell, here's the question. Forget about the EDI down here. If you would see this waveform over here, is the cycle, so remember the patient is the PMOS, the patient is the reference. Is the cycle early or late on this patient?
To be early.
So early means that it ends earlier than the patient. Do you see evidence of effort earlier, that the patient is still doing effort over here?
Yeah, that patient, no, there's no effort there.
So if I read this waveform, you would say it's late, Eduardo. Look, it's flat. There's no evidence of effort. This patient is getting no flow, so the patient is doing no PMOS. So this is late cycle. Does that make sense?
Yes, it does.
Yes, it does. So, however, I just told you that this is NAVA, and this ventilator cycles at 70% of the peak, which is exactly where it cycles. It followed what the instructions are. It cycled right when you told him. So if you are doing a study and you don't have EDI, you would say this is late cycle. But now that you have the EDI, you say, no, this is not late cycle. The patient was still doing effort. And the ventilator cycled appropriately. And the reason why it didn't cycle, why this looks like there's no effort, in part it could be because we limited the flow, not the flow, the pressure, but in big part it's because this patient has neuro-mechanical coupling, so uncoupling. So meaning that the patient wants more and it's doing all this effort to achieve that, but the muscles cannot contract anymore. They cannot generate any more flow because of the characteristics of the lungs, of the elastic characteristics of the lung, because the lung is restricted and it doesn't take any more in spite of you doing still effort. And the way that I understand this is, for example, when you move your arm and contract it, your neural signal is being manifested as a mechanical signal. But if I get to the end and I'm still contracting and the muscle is not, the signal is still showing, but there's no evidence of action on the muscle because it's not contracting. There's no displacement. Does that make sense? Rob,
And
comments?
so you're saying,
Good.
following the flow, that's why we see that that issue right there, is because the diaphragm can't contract anymore, and so it's kind of stopping the flow.
Either the diaphragm cannot contract or the lung cannot expand anymore. But you
Okay.
don't see any more movement, or it's very little, and you cannot see it, but there it is. Go ahead, Rob.
Nope, looks good.
So this is an area that, I mean, this will permeate into your lives as you start going ahead on your career, and this NAVA becomes more, or is being used. The studies are going to be a challenge to interpret, because as I read these three waveforms, it may be that I'm missing information that obviously the EDI is giving me, that provides even more information than what you had.
So Dr. Mireles,
Yes, go ahead.
this is Mohammed. So is this a shortcoming of NAVA, or is this like a physiological limitation where, like, looking at this?
No, this is this is not a negative. This is a positive in a way. But what it opens is the field. I mean, what I have been teaching you all this time, obviously, is to read the waveforms, and the majority of the time, as you saw on the past, the waveforms tell you the same as the EDI signal, or very close to what it is. But there are situations in which there's going to be mechanical uncoupling, and then under these circumstances, this helps you understand a little bit about the physiology of the individual. I mean, this person is requiring a lot of support to maintain the tidal volumes at where they can. They're doing a fair amount of effort, actually, a very large amount of the EDI is very elevated. And even with that, they're not generating as much. And so you could argue, under these circumstances, is this good or bad for the patient? Is this hurting the diaphragm? And should we just use another technique and not have that diaphragm working as hard as it is?
It's a good point. An EDI peak above 15 to 20 is very extremely high.
So
this is even way above that.
It is. So, I mean, it could be misplacement, it could be other issues involved here, but the key message is that as you start evolving through this, just there's much more for us to learn on this the synchrony world, that beyond what we can normally see. And sometimes you're going to need either an esophageal balloon or an ADI catheter to help these patients, and to actually provide information in our studies that actually makes sense. So you can imagine that this is completely different. Well, I have made my point already. I will stop there. I thank you, everybody, for all your input. And here's the code for those that want a CME to be obtained. That's the code DBY441. And then if you want to share the SEVA webpage so that they can come and join us, or you want to send us your Twitter, your waveforms, as you can see, we're learning from all of this. Thank you very much. Have a great day.